All right, welcome everyone. We're so glad you can join us for today's community talk, which explores the role of psychedelics in psychiatry, specifically for depression. Together, we'll dive into the science behind psilocybin and its efficacy in depression, as well as diverse representation in psychedelic research, and then discuss the importance of culturally responsive approaches to care. We're very honored to have Dr. Ishrat Husain guiding us through this important conversation. My name is Harleen, and I'm currently a graduate student in clinical psychology at Toronto Metropolitan University. Together with Dr. Rabin, I co-founded Cortex Conversations as a way of connecting to the community. We share a passion for science communication and believe that translating important scientific discoveries into accessible information is key to improving lives. So whether that is in person or online, we aim to host free, open talks that make these essential topics accessible to everyone. With that being said, today's moderator is Dr. Jenny Rabin. She is a registered clinical neuropsychologist, a scientist at Sunnybrook Research Institute, and an assistant professor in the Department of Medicine at the University of Toronto. After earning her PhD in clinical neuropsychology from York University, she completed her internship and a 3-year fellowship at Harvard Medical School. In 2019, she started the Cognitive Brain Health Lab at Sunnybrook Research Institute, where she continues to conduct her own research. And now I'll hand it over to Jenny to introduce our speaker.
Thanks, Harleen. So it's my absolute pleasure to introduce Dr. Hussein today. He is the Cameron Wilson, he holds the Cameron Wilson Chair in Depression Studies and is an Associate Professor of Psychiatry at the University of Toronto. He is also the Department Head and Program Director at the University Health Network Center for Mental Health and serves as the Program Medical Director for the UHN-CAMH Partnership. He's leading numerous trials for psilocybin therapy and depression, and we're lucky enough for him to take the time out of his busy schedule to tell us about psilocybin and its implications for depression, particularly in diverse communities. So please give a warm welcome to Dr. Ishrat Husain.
Thanks, Jenny and Harleen, for the kind introduction and for the opportunity to be here today to speak about an area of increasing interest, not only in the scientific and clinical community, but also within public dialogue. And that is about the potential role of psychedelics like psilocybin as an emerging treatment for mental health problems. So in terms of my disclosures, there's no conflicts of interest with the talk I'm about to deliver. I have led some contracted research for industry sponsors of psychedelic therapies, as well as done some advising to psychedelic startups. In this lecture, I hope to be able to tell you what a psychedelic actually is, in terms of its medical context, and also to describe as best as I can, the ways in which psychedelics may help improve symptoms of psychiatric illness like depression. I'll talk about some of the emerging evidence from clinical trials of psychedelic therapies in mental health conditions. I won't be covering the evidence from the use of psychedelics in other conditions like substance use disorders or addictions. That is a growing area of interest, but the topic is simply too big to be able to cover that all today. And my own clinical interest is in the management of psychiatric disorders rather than addiction. So I'm sticking to what I know. I will then conclude by talking about some of the real challenges that exist within psychedelic research at this point. And a lot of it relates to the importance of including diverse communities into psychedelic research, increasing the diversity of the samples of patients that are coming forward for this, particularly with regards to ethno-racial backgrounds. And, if these do become treatments that make it to the mainstream, we really do need to ensure that the evidence is representative of a population like the melting pot that we have here in Toronto as well. I'll also speak about some of the barriers that are currently in place that need to be addressed before psychedelics are ready for clinical use. So why are we here today talking at this public forum on the use of what are traditionally recreational or street drugs like MDMA, often called ecstasy, magic mushrooms or psilocybin, or acid called LSD, as potential therapies for mental health and addictions? Well, there's been a lot of excitement around this area. Here are just some selected headlines that I've grabbed from mainstream media outlets like the New York Times, The Guardian in the UK, really heralding psychedelics as this new frontier in the treatment of mental health conditions, something that could transform mental health care. So this has created somewhat of a hype bubble, not only within medicine, but also in the public discourse. There isn't a week that goes by where people aren't asking me about whether they should be integrating psychedelics into their own lives to optimize their mental well-being or cognitive function. But where did all of this hype come from? Well, it's because there have been some proponents on the use and the benefits of psychedelics in the mainstream media as well. You can see here a book cover on the left, best-selling book, How to Change Your Mind, a nonfiction book written by an investigative journalist, Michael Pollan, who spoke about his own journey and experience with the use of psilocybin, also chronicling the history of it. This was made into a very popular Netflix series a couple of years ago as well, which really increased attention to this area. And then on the right, you've got Tim Ferriss. He is another best-selling author, but also a prominent podcaster who has been very open about his own struggles with treatment-resistant depression and how he has really benefited from the use of psychedelics in his own treatment. In fact, in one interview, he said he's not had a single depressive episode since he started using psychedelics. So these people with captive audiences have really led to this outpouring of excitement around this emerging area. But what exactly is a psychedelic? Actually, psychedelic is a term that was coined only within the last 100 years. It's a new term. It's something we call a neologism because it was a term that didn't exist before the mid 20th century. And it was coined by a Canadian British psychiatrist who was studying the potential therapeutic uses of these substances. And initially, the term that was used to describe these drugs was something called psychotomimetic, something that mimics a psychotic illness. But actually, they found that that term didn't adequately describe them. And they felt that psychedelic, which comes from ancient Greek and means mind manifesting, was more adequate because these are substances that produce profound psychological effects, quite meaningful insights, some spiritual experiences, as well as changes in mood, thoughts, consciousness. So they felt that a psychedelic, something that reveals what's going on in one's mind, was more an appropriate term. It's not a official classification of a drug. Generally, when we talk about a psychedelic, we use it as a term to describe these substances that cause these profound psychological effects and changes in consciousness. They're generally drugs that act on a particular receptor in the brain. That's the receptor of the chemical serotonin, which some of you may have heard of, is sometimes called the happy chemical. And it's often implicated in the onset or persistence of a depressive illness. In fact, traditional antidepressant medications are there to increase the amount of serotonin in the brain, although it's a controversial area and yet to be determined whether it's actually that serotonin reduction that causes depression. But back to psychedelics. So psychedelics tend to have quite a prominent action on that particular chemical serotonin. When I'll be talking about them, I'll be talking about substances like psilocybin, MDMA, LSD, as well as ayahuasca and DMT. Ketamine is sometimes looped in as a psychedelic, but actually ketamine is an anesthetic drug and a painkiller that's been around since the mid 20th century as well. The way that it's administered in clinical practice is very different from the way that psilocybin and other psychedelics are administered for therapeutic use. So for the purposes of this lecture, I'm not going to be referring to ketamine as a psychedelic, and I personally feel it's more a dissociative anesthetic that has a very different mode of action in terms of its therapeutic effects. So what are psychedelic drugs? Several of them are plant extracts. So psilocybin is extracted from the Psilocybe genus of mushrooms. LSD, although synthetic, also is a derivative of a plant extract. Mescaline is derived from the peyote cactus. MDMA is purely synthetic. The plant extracts or the naturally occurring psychedelics have actually been used for centuries across cultures to induce hallucinogenic and spiritual like experiences. There's even some reports from ancient Sufi culture that some Sufi saints used to use psychedelic substances to sort of reach that higher level of enlightenment. In terms of more contemporary research and clinical trials, most studies have used psilocybin, MDMA, and LSD, and they've often combined it with a form of psychological support or therapy. The way that they really sort of were discovered as having potential therapeutic effects was when they were first isolated. Psychiatrists and psychotherapists at the time had very little in terms of treatment options. There was no antidepressants available at that time, and the main modality of treatment was psychotherapy. So when people were stuck in psychotherapy and when these drugs were identified, psychiatrists and psychotherapists started to use them in their therapy sessions and found that it seemed to unblock people that weren't getting better with psychotherapy. In terms of how they were discovered, this is probably the sort of godfather of psychedelic medicine, a gentleman called Albert Hofmann, who's a Swiss pharmacologist. He actually synthesized LSD while he was working at a Swiss pharmaceutical company called Sandoz. And then almost 2 decades later, he isolated psilocybin from the Psilocybe genus of mushrooms. And then in the 50s and 60s, the company he was working for actually marketed these drugs. And there were several clinical trials across North America and Europe looking at these compounds. At one point in the US, the NIH had funded over 130 different clinical trials. Now, of course, at the time, the research wasn't as rigorous as it is today. There weren't the same checks and balances. There was a slip into recreational use, and quickly they became associated with the anti-Vietnam War movement, leading to bans by the Nixon administration in the US. And then soon after that, most psychedelics were classified as Schedule I narcotics at the 1971 UN Convention on Drugs, although even at that time, there was very little evidence of actual harm that had been published or identified. I'm going to sort of briefly go over the pharmacology or the sort of the chemical action of these substances. I mentioned serotonin and the actions of a lot of these drugs at the receptor of that particular chemical. They act at various receptors of that chemical, but the 5-HT2A or the serotonin 2A receptor is the one that's key. We know that that's the one that causes those sort of deep, profound sort of insights, the sort of perceptual disturbances, the visual hallucinations, because when we block that particular receptor with another agent, like another medication, people do not have a psychedelic experience. So we know that that is responsible for some of the perceptual disturbances. What we don't know is whether that's also responsible for the therapeutic effects, because a lot of these drugs act in other parts of the brain as well, not only at other receptors, but they also lead to increased communication between regions of the brain and increased connectivity as well. MDMA is a little bit different. It acts by causing a large and rapid release of presynaptic serotonin, as well as norepinephrine and dopamine, which are like activating chemicals. So this is why it's often associated as being a party drug and in the rave culture, because it gives people the energy to be able to dance and keep going all night. I won't spend too much time on this. It's quite a busy table and quite technical, but essentially what it summarizes is that most psychedelics are administered orally, so they're taken by mouth. Generally, most take up to an hour to 90 minutes to take effect, and their duration of action ranges anywhere from 20 minutes for DMT when it's taken orally, all the way up to 12 hours for LSD. When we are investigating for clinical use psilocybin, we generally find that the effects last 4 to 6 hours, which means that the patients that are in for therapy with us are with us for the whole day. We do want them to come into hospital to receive the treatment because we want to ensure that they're safe and that they're under continuous monitoring and that they're receiving that psychological support with trained therapists during their treatment sessions. So again, I won't spend too much time on this. This is a diagram that sort of models what the serotonin 2A receptor looks like. It's actually expressed all over the brain and body. It's not just within the central nervous system. And so when it's activated, it really depends where in the body it's been activated to lead to its effects. But in the brain, it's thought to modulate memory and executive function, attention, amongst other things as well. But in the body, it leads to smooth muscle contractions, dilation of the blood vessels, as well as constriction of the blood vessels. So the effects of activating that particular receptor really vary where in the body that activism is occurring. As I mentioned earlier, the mechanism of the psychedelic effects is thought to be mediated by the 2A receptor because, as I said, if you block it, you don't get the psychedelic effects, but we don't know what happens downstream once that 5-HT2A receptor is activated. We don't know why somebody has a visual hallucination or why sounds sound, clearer, or why you have that experience of seeing sounds, or why you have these sort of spiritual like experiences or feelings of connection with others. That's yet to be fully understood. We do know, however, that other chemicals may be involved, like glutamate, as well as other serotonin receptors. For LSD, we know that dopamine receptors may also be involved in its actions. So onto those psychological effects, I spoke about how they can be quite meaningful and powerful. Here is a list of some of them, like feelings of enhanced sociality, feeling close to others, feeling open to new experiences, having a deep sense of emotional empathy, trust, feelings of bliss, and then these mystical experiences characterized by something called oceanic boundlessness, feeling one with the world, as well as being very introspective into one's own self. I spoke about sounds and sort of visual perceptual disturbances, and that can often be the experience of synesthesia, in which one sees sounds. So that's why music can be a quite key component of the therapy as well. There can be some negative experiences. People sometimes don't feel quite right in themselves. That sort of idea of depersonalization, or that they're not in a real world, derealization. Sometimes people feel quite anxious and fearful, and they need to be calmed down through our trained therapists. Sometimes people can be quite frankly paranoid, or feel a little bit, distressed in terms of their mood, as well as having auditory hallucinations, although this is not common with MDMA at the doses that we use for therapeutic use. In terms of adverse effects, so these are negative side effects. 40% of recreational users will report these, and they're listed in this table here. And by and large, they're quite mild and transient. Things like pupil dilation, mild elevations in blood pressure or heart rate, feeling a bit dizzy or nauseous. All of them are kind of short-lived. They last sort of the duration of the drug effect, and then they tend to go away. About 8% of people, and this is recreational users, have reported enduring psychological symptoms. These may include things like anxiety post-treatment, but also this includes positive psychological changes as well, like feeling, more at ease, more comfortable as well. So this is data from recreational users, not necessarily those with an underlying mental health condition. I'll talk a little bit about the science of what we think these psychedelics are doing to the brain. This is an image of something in the brain called the default mode network. It's a circuit within the brain that's thought to be particularly active when one's very much in their own internal world, sort of ruminating on things, daydreaming. And this particular circuit is thought to be overly active in certain mental health conditions like depression, trauma, obsessive compulsive disorder. And it's thought that actually psychedelics disrupt this circuit and lead to sort of a reintegration of that circuit in a more sort of adaptive, healthier manner. So this is some data from healthy folks that are under the influence of psilocybin, showing a reduction in blood flow over the area that sort of maps over the default mode network compared to if they took a placebo. And then again, this is data from healthy people showing a reduction in blood flow, but increased connectivity in areas that map over the default mode network. So again, showing that perhaps it leads to a reduction in activity over that circuit, and then a reintegration or rebuilding of that particular circuit. This is work in healthy folks undergoing brain imaging while they're under the influence of another psychedelic, LSD, showing increased connectivity in areas of the brain that actually map over the serotonin to a receptor. So again, the sort of concept that psychedelics may help parts of the brain that weren't communicating properly prior, it sort of leads to that increased connectivity and communication. So, I spoke a little bit about the history of psychedelics. In the 1950s and 60s, research was really flourishing. But then, you can see sort of through this graph where it sort of flatlines that from 1970 up until the sort of early 2000s, when research started to increase again, there was no research because they became controlled substances, Schedule I narcotics, and it was very difficult to access them to be able to conduct that research. But then you can see sort of mid-2000s that the research really started to ramp up again, and the psychedelic renaissance, as it's so called, began. And this is after some investigators in North America and the United Kingdom began to sort of slowly investigate particularly psilocybin and its therapeutic uses in conditions like OCD, depression, and so on, as potential therapeutic avenues. And from their small trials, they showed really, really sort of impressive results. Some folks who were sort of totally in remission from their depressive illness that hadn't responded to multiple different antidepressant medications. Some folks that weren't on any therapy for almost a year after receiving psilocybin therapy. So this started to garner a lot of attention. And then a substance like MDMA was being investigated in small clinical trials for post-traumatic stress disorder. And again, positive results coming from those small trials, leading to, both for-profit and non-profit sponsors of this research starting to support larger studies. These are some early clinical signals on the antidepressant effects of psilocybin. This is data from the early clinical trials from the US and UK in populations ranging from those with end-of-life distress, end-of-life mood and anxiety issues in cancer patients, as well as those with refractory depression. And the graphs here really indicate the picture. This is what we as clinical trialists want to see. We want to see folks that have high depression scores showing a reduction in depression scores at the end of the clinical trial. And you can see that in each of these studies, a reduction in depression symptoms following psilocybin therapy, which again led to a lot of excitement and a growing area of research looking at psilocybin therapy and other psychedelics as potential novel therapeutics for mental health conditions. So after that, the mid 2000s, there was, a slew of different studies looking at psilocybin therapy as an antidepressant. We were involved in some of this work, and our team pulled together some of the data from these clinical trials. And really, what this graph shows is that when you pull together all the data from the published clinical trials, even what we do is take the small studies, we put the results together with the bigger ones, and you can show that compared to a placebo or a control condition, psilocybin clearly outperforms control conditions as an antidepressant treatment. So, clearly these early studies that have smaller sample sizes suggest that we need to do bigger studies to confirm these effects. But one of the main issues with psychedelics, as I mentioned, those powerful psychological effects that they have, is that it's very difficult to blind somebody in a clinical trial, whether they've had a placebo or a psychedelic, that everybody can guess correctly that they've had the psychedelic. For us as researchers, this is a real issue because if somebody knows that they're getting the active drug, then that introduces bias into the findings. Because the best way to actually, or the most robust way to evaluate the evidence is to do it when the investigators and the trial participants and the folks that are doing the ratings of the symptoms don't know what the participant has had. And that's very difficult to do with psychedelics that have such profound psychological effects. And we did find actually when investigators use drugs that have some sort of psychological effect, whether that's an antidepressant or not, then the antidepressant effect isn't as large compared to when they're using an active placebo. So really what we're starting to do in our trials is we're comparing full doses of psilocybin to smaller or micro doses to see whether it's the full dose that has the antidepressant effect or not. So we're also looking at psilocybin therapy for bipolar depression. This is a small study of 15 participants with bipolar type 2 disorder who underwent psilocybin therapy, and they had large and sustained antidepressant effects. This was a study conducted in the US near Baltimore, but we have collaborated with this group and were able to obtain some funding to do this work here in Toronto and in Canada as well, which we're hoping to start shortly. So in terms of how psilocybin or other psychedelics may cause antidepressant effects, the answer is that we don't fully understand. We're trying to do the work to delineate that, but at the moment it's felt that the serotonin receptor activation may be involved. It may be the sort of biological, psychological, social, and spiritual effects of that mind-revealing experience. It may be increased connectivity due to the growth factors that are being released and neuroplasticity. That's the brain's ability to change structure and function in response to stimuli. It may be due to changes in that circuit that I mentioned, the default mode network, or it may be due to anti-inflammatory and antioxidant effects. Psilocybin in particular is a very interesting drug. I started my career looking at the role of inflammation and depression, and there's evidence that about a third of people with depression have an inflammatory process. And in fact, some studies of anti-inflammatory medications has shown that by reducing inflammation, you may improve depression. And so perhaps that's also at play with a substance like psilocybin. And of course, we can't get away from the fact that a lot of people come into these studies with a lot of expectancy. It may be, placebo effects are common in trials of depression, and so that may be playing a role in psychedelic research as well. So some people have tried to understand a little bit about what's happening in the brain of people with depression that undergo psilocybin therapy. This is a group from London in the UK who did MRI scans of individuals who got better with psilocybin therapy, and they showed that an increase in connectivity in that network, the default mode network, suggesting that, as I mentioned previously, that once you're under the influence of psilocybin, that network kind of resets itself. So it disintegrates acutely, and then after the treatment, it kind of rebuilds itself up to be more adaptive. This is still purely speculative and hypothetical. We need to sort of confirm this in larger and independent samples, but it's an interesting observation from a sample of 16 people with depression. And then the same group also looked and pooled together data from more patients. This was, I think, almost 70 patients that they were able to look at connectivity within regions of the brain. So they found that compared to a traditional antidepressant, escitalopram, those that received psilocybin had increased connectivity with regions of the brain that weren't previously connecting with each other. So again, adding to the hypothesis that perhaps psychedelic therapy liberates a brain or a mind that's been stuck in a negative pattern for so long. And then, really, since then, there has been a slew of studies looking at psychedelic therapies of different forms, including MDMA, PTSD, LSD, for a variety of different mental disorders. I've summarized this in this trial, in this chart here, and you can see, a lot of different conditions. The main ones are depression, PTSD, and anxiety disorders. But people are looking at psychedelic therapies for everything, including chronic pain, sleep, dissociative symptoms, and others as well. And most of these studies are reporting positive effects. But it's not all sunshine and rainbows. There are limitations with all of these studies as well, which I'll talk about. And some of them are here. Like you can see here, some of the sample sizes and the number of participants in each study. Only 6 here, which is, it's very difficult to draw much in way of evidence from that level, that small a sample. So that's just something to be aware of. This is just a chart going through the adverse effects. Again, it's a busy table, but I'll summarize that most of the adverse effects or the side effects reported in these clinical trials tend to be mild and transient. There have been no serious adverse events in any of the reported studies. It seems so far that these compounds appear to be safe for use in clinical populations like depression. So, there was a lot of excitement about this area. So we got together as a group of experts in depression treatment, and we put out a position statement. And this was a couple of years ago, but I still think it stands. We still consider psilocybin and other psychedelic therapies as experimental treatments at this point because we don't have data from large studies confirming its safety and effectiveness. So we do advise patients to access these particular therapies only through clinical trials or in rare cases through the Health Canada Special Access Program, in which a specialist physician can apply for the use of psychedelic therapies for their patients if there is evidence that all other available treatments have been tried and have not worked. I will talk a little bit about the psychological support because this is not just a drug-only treatment. We do give a form of psychotherapy with the administration of the drugs. We do up to 4 hours of preparation sessions, so that's divided into 1 or 2 visits. And then during the actual administration of the drug, we provide psychological support for up to 8 hours with trained therapists, and then at least 2 hours of post study drug administration integration sessions that are again divided into to usually 2 sessions. The type of therapy is loosely based on acceptance and commitment therapy. Really, the aim is to focus on psychological flexibility for the patient to be able to adapt to fluctuating demands while they're in the dosing session. It's really about shifting perspectives and previously held negative beliefs, and balancing, different desires and needs during the actual dosing as well. It's thought to be very important to minimize risks and to maximize the therapeutic benefit. And some data has shown that, if you have a good alliance with the therapist, you set an intention, you trust the therapist, then you'll have a better outcome with psychedelic therapy. Interestingly, music listening and particular types of music like classical and ambient music are associated with better outcomes as well. Generally, the model is to use 2 therapists. However, we now have found that actually using 1 therapist is sufficient as long as you have somebody that can sub in to support the patient if the therapist needs to take a break, for instance. So these are just some qualitative reports from some of the studies of psychedelic therapies, and you can see themes here on some of those psychological effects that I spoke about. People, for example, saying that MDMA gave them the ability to feel capable to tackle issues, um, of sort of giving them the tools to be able to fight their mental health problems. Here in LSD assisted therapy, they feel again that the drug seems to enrich the therapy and the introspection. You again learning a lot about oneself, speaking to that introspection when you're receiving psychedelic therapy. And then the themes of unity and connectivity as being one with the world around people, themes of love as well, as sort of this sort of nice metaphor of having a veil drop before one's eyes. And that sort of, again, that feeling that this persists even beyond that dosing session. It's something that seems to stick with people following that treatment session. However, as I mentioned, it isn't all sunshine and rainbows. There are issues with a lot of the published studies. Most of the studies have been small sample sizes, although larger studies are coming out. We were involved with one of the largest, in fact, the largest, and we are now involved with what's going to be considered the definitive trial of psilocybin therapy for depression, over 500 people. Um, we have to sort of recognize that expectancy plays a huge role. Like people come in to these studies really believing that this is going to transform their experience. And we know that when somebody comes in with that expectancy, that can bias the results and the findings. The lack of blinding, as I mentioned, is a huge issue. Almost 100% of people know which arm of the study they've been allocated to, which is problematic. We don't know what the best comparator is, so we've landed on a low dose of a psychedelic to help us compare the effects. Most of the samples, and I'll get onto this in a second, are very homogeneous, and I don't think they're representative, as I mentioned, of the community and the patients that we're seeing here in Toronto. They're highly selected, often, middle class white folks. The eligibility criteria is very stringent. The studies are very short duration. We don't know what the optimum dose is. Not a lot of assessment of actually the psychotherapy piece and how that changes from case to case and how that might impact the outcome. And yet, as yet, we still don't fully understand what the mechanism of the effect is as well. And then I'll speak a little bit about the need for the diverse samples and how important it is to reach out to these communities. So we know, for example, that levels of psychological distress in people of color, underrepresented populations is higher to those white participants, non-Hispanic white participants in particular. And we know that these underrepresented communities, due to barriers to access, stigma, are not able to access care for their mental health problems. And as a result, they have also then little access to, state-of-the-art research protocols as well, because most of the recruitment drives for these clinical trials are through direct referrals from clinicians, whether that's, a family doctor or a psychiatrist. That's how people refer into studies of psychedelic therapies. And you can see from this data, irrespective of the country, even in a country like Mexico or Brazil, the majority of the participants tend to be white. And you can see if you pool together all, and even though this is data from a few years ago, I don't think it has changed much, that over 80% of the samples recruited to these studies are white Caucasian. And again, because this is a complex intervention that involves not only just drug administration, but also the psychological support and it's, the sort of spiritual experiences that one may experience with this. Really, we do need to include those diverse samples to see whether those experiences, change from sample to sample or community to community or culture to culture, whether we need to take a culturally adaptive approach to the psychological support model, whether the actual psychedelic experience leads to better outcomes in these communities. So really, we are on a drive to try and increase the representation of our samples in our trials here in Toronto. And some of the strategies that we're using is that we're trying to diversify our recruitment methods. We're not solely relying on referrals from clinicians within our organizations. We will accept referrals from community organizations. We have reached out to community organizations to try and give workshops and raise awareness on this particular area as well. And also, I think it helps having to have diverse research teams, having somebody like myself, a person of color who identifies as, a Muslim immigrant studying this, I think can help as well in terms of trying to recruit diverse samples to our studies as well. But despite all of these limitations, the psychedelic train keeps rolling. The sort of picture here is of a mushroom dispensary just, a block or two away from CAMH, where you can actually walk in and sort of just buy psilocybin mushrooms to sort of self-administer for your mental health problem. This is problematic because the way the impact that would have is uncertain at this point. We only administer the substances in controlled settings with trained personnel that are supporting people through it. And really, if people are, increasing the recreational use, then it means that a lot of them can't participate in the studies that we're taking part in. So this is hugely problematic, and I think most street corners have a mushroom dispensary now. So sort of the train has left the station, and really our job is to try and raise awareness like I'm doing now, and sort of tell folks that there are risks associated with recreational psychedelic use as well, particularly if you have a personal or family history of a serious mental health condition like a psychotic illness or bipolar disorder. You would be prone to some of the risks of these substances. I'm going to briefly touch on microdosing because this is something that I get asked about a lot. So microdosing is very different from what I've talked about earlier. It's taking a fraction of the dose of what we are currently studying for clinical development and taking it, a few times a week to try and optimize mood, psychological sort of well-being, and your sort of memory, attention, and so on. It doesn't lead to any sort of feeling of intoxication or inebriation. It doesn't have any behavioral disruption. It's as I said, a fraction of the dose. It really came to prominence from this American psychologist, James Fadiman. But really, in terms of the evidence for its benefits, it's really, really weak. There's some anecdotal reports from surveys that there's positive effects, but clinical trials in healthy folks have shown that actually it's largely a placebo effect that's contributing to that perceived benefit. We have been involved in a trial of microdosing for major depressive disorder, but the results of that are still outstanding at this point. And we really do need to do a trial in clinical populations to see if they have any therapeutic benefit when taken as a microdose. So I'm just going to briefly talk a little bit about the psychedelic research we've been involved in at CAMH and now at UHN. So I mentioned that we were involved in the largest study of psilocybin therapy for treatment-resistant depression. It was a study of over 230 people, and we found that we tested 3 different doses of psilocybin. So a micro dose of 1 milligram, a sort of medium dose of 10 milligrams, which would lead to perceptual disturbances in about 50% of people, and then the full sort of dose of 25 milligrams, in which 100% of people would probably have that psychedelic experience. And we showed that the largest antidepressant effect that we saw was with a 25 milligram dose. Although all arms of the study showed some improvement in their depressive symptoms, it was the 25 milligram dose that really outperformed. And that's the one that's being taken forward for further testing and clinical development. It was a pretty well-tolerated treatment. There were a few serious adverse events from people reporting suicidal ideation following administration of the study drug. But that was interestingly mostly in people that didn't get better with the therapy. And we think that, again, that whole hype and expectancy played into that because people came into this expecting it would transform their life, and when it didn't, they felt worse in their mood and felt suicidal. But it is something that needs to be carefully evaluated in current studies. So I'll just sort of go through some of the treatment experience. I talked about the preparation sessions. We taper people off of their antidepressants and other medications that interfere with the serotonin receptor because that's thought to sort of dull the effect of psilocybin therapy. We exclude people with any other serious major mental health problem like schizophrenia. We really do a lot of work with preparing folks. And then what we do is we administer the therapy and the drug in a non-clinical environment. So like a bedroom, living room type environment. We have ambient lighting and a music playlist and so on throughout the session. So what we're doing is answering some key questions in the field of psychedelic research. We're trying to understand whether you need that psychedelic trip or that psychedelic experience to have antidepressant effects. I mentioned that these substances aren't exactly clean. They act in various parts of the brain, and we don't know yet whether you need that, sort of visual disturbance, mind revealing experience to have antidepressant effects, because we're not sure if the neuroplasticity or the connectivity is dependent on that. And in fact, in some studies in animals, in which they've sort of, you know, induced a depressive-like state in a mouse, they've shown that even when you block the serotonin receptor that's responsible for the psychedelic experience and you administer a drug like psilocybin, the mouse can still have antidepressant-like effects and be more interested in things and so on. So it's still a hypothesis worth testing in humans, and that's what we're doing now. We were pleased that, we were the first group that the Canadian government funded to conduct a study of psilocybin research. And the whole premise of the study is to try and understand whether you need that psychedelic trip to have an antidepressant effect as well. We're involved in a lot of different other studies, and I'd be happy for folks to ask questions about these. So these are our trials in depression. We're looking at psilocybin as a treatment for treatment-resistant depression. Some of them involve brain imaging as well, in which we're trying to understand what psilocybin's doing to the brain of folks with depression to get them better. We're also doing studies, large studies, in which we are testing multiple doses of psilocybin as well, because we're not sure whether it's just a one and done type treatment or whether you need repeated dosing. We're looking at psilocybin for other clinical populations, so for people that have depression and chronic pain. And we're also trying to understand the role of the psychotherapy piece. Like, what is the dose of the psychotherapy piece? Does everybody need those sort of specialized trained therapists to be with them during and after the treatment, or is it something that can be done by another member of the clinical team in which they sort of just monitor the patients for safety? So I'll just conclude by saying that, there's been a growing evidence for, the rapid and sustained effects of psilocybin for depression and MDMA for PTSD. But as I've summarized, the treatment is actually a very complex procedure. We do properly screen and prepare our patients. There's lots of issues with the design of the current clinical trials, including a lack of generalizability to diverse racial and ethnic groups. We need to do larger studies that are well designed, that include diverse samples to determine the optimum dose, the safety, effectiveness, and how these treatments are actually working. So with that, I will stop, and I'd be happy to take some questions to be able to discuss some of this.
Thank you, Dr. Hussein, for such an informative talk. So I will get into some questions that have been put into the chat. Some have already been answered, but maybe if you'd like to expand on them. So the first question is, will the drugs work for people with anxiety disorder?
It's a really interesting question because up to 70% of people with depression would also have anxiety. And actually, when we've looked at the data from those individuals, we've shown that anxiety symptoms also improve with psychedelic therapy. There have been some trials of LSD specifically, showing that LSD assisted therapy improves symptoms of generalized anxiety disorder as well. So it seems that, yeah, that these treatments do have anti-anxiety effects as well. We are designing some studies in social anxiety disorder to look at the role of psilocybin therapy. Um, but it seems that those that have both depression and anxiety, the anxiety seems to get better too.
Very interesting. Just to kind of bounce off of what you said in terms of LSD helping with anxiety, do you find that different kinds of psychedelics might be a bit helpful for different kinds of disorders, or is there just more research that needs to be going into that?
It's a really interesting question because, certain psychedelics have been used for particular conditions. So MDMA early on was identified as a potential treatment for PTSD and has, got really compelling evidence to suggest that it will. Um, but also in those studies, MDMA improved depression, it improved anxiety. And then psilocybin was selected as a candidate for depression, but I suspect it also works with other mental health symptoms as well. Um, I think as a group, what they're doing is they're having this serotonergic effect that probably is allowing these folks to engage meaningfully in a psychological intervention at the same time, which then improves a number of different mental health symptoms, whether that's anxiety, trauma related, or depression. Interestingly, all of these conditions come under the sort of umbrella of internalizing disorders when people are very much in their own internal world. So it probably disrupts that a little bit. So that's why I think that they broadly will probably work. The thing is which I didn't touch upon, is the practicality of being able to scale all of this up. LSD has a very long duration of action, and that's why we have chosen not to study it because it would mean that we'd have to keep people in hospital overnight. Like if their experience goes on 12 hours, it's very hard to do that. And so we selected psilocybin because it's got 4 to 6 hours. We're now going to move on to shorter acting ones as well, like DMT, which may have a shorter acting action. And that's an untested question. Like how long does the experience need to be for it to be therapeutic? And in fact, we're going to design a trial to answer that.
It's very interesting. The next question is, I've heard people with schizophrenia and their family are more likely to experience psychosis from psychedelics. I was wondering who definitely should not use this sort of drug.
So that's correct. Theoretically, an individual that has a first degree relative with schizophrenia or a psychotic illness is at a higher risk at baseline. Adding in a psychoactive substance like psilocybin or a psychedelic could increase the risk of inducing a psychotic illness. So that's why Health Canada and investigators have been cautious and not included those folks in psilocybin studies. I always advise patients, if you have a personal or family history of a psychotic illness, you shouldn't be taking anything that messes with your mind or your brain. Yes, I think there are groups that should avoid these substances that have these sort of psychoactive, mind-altering effects. And those groups would be those like schizophrenia, personal history of schizophrenia, particular types of bipolar disorder, like type 1, where if you've been manic or had a history of mania, then I would avoid that.
Okay. We have another question here. What does data tell us about dependence if used for therapeutic use?
Really interesting question. So there have been a couple of long-term follow-up studies. By long-term, I mean like a year following the therapeutic use. And seems to be zero risk of dependence. If you look at even recreational users, the risk of physiological dependence is extremely low. Theoretically, there is a risk of psychological dependence on them, but it seems that the rates of even that are very low. Compared to something like alcohol, like the risk of dependence is much lower with these substances.
Okay. So one question we have here is from a student. What is Dr. Hussein's advice to Canadian students interested in becoming a psychedelic assisted psychotherapist or research in psychedelics?
So if you want to become a therapist, what you have to do is go down the training to become a registered psychotherapist in your province. So that would mean pursuing a professional vocation that would allow you to do that, whether that's social work, psychology, nursing, etc. And then get psychotherapy training because that, is mandated by Health Canada that if you want to be a psychedelic therapist, even within clinical trials, you have to have that particular professional background. And then there are courses available to be able to get some hands-on experience in psychedelic therapy as well. We have one at UHN. And then to get involved in psychedelic research, I think, it's a matter of reaching out to groups that are working in this area, depending on where in the city or where in the province you are, and sort of seeing whether they're recruiting. I will say a lot of people want to get involved in this area. And so, it's pretty saturated. But I'm sure, it's a growing area, so there's ample opportunities.
Great. Well, we have many questions coming in, but the next one is generally how open are individuals to participating in these studies? What's drawing people in and what hesitancies might some have?
So these people are very excited about this area. I mentioned that hype around it, the media coverage, and so on. People are very put themselves forward quite easily. Whether they're appropriate for it is a different question because a lot of the individuals have complex mental health problems. They have personal or family history of problems that would like exclude them from doing this, or they, haven't tried other treatment options that are evidence-based and they're trying to jump straight to this. So that sometimes, prevents their participation. For those that are hesitant, to be honest, though there are people that are hesitant about that acute mind revealing experience. They're scared and anxious about the fact that this can cause visual hallucinations or, disrupt their mind in some way. And that's where the hesitancy for a lot of folks comes in because they think, is this going to permanently make me see things or hear things and things like that? So a lot of it will involve just educating folks about it.
Interesting. Do you tend to find that there's also a stigma that comes with people who are hesitant about it, or is it more so?
Yeah, yeah. So exactly right. Like so, like they're traditionally street drugs, and they're sort of seen as that by some groups, some cultures. I think less so, to be honest, in a place like Toronto and the sort of with time, I think that some of that stigma is really coming down. But there's still certain cultural groups that see it as a bit of a stigma, a bit of a taboo. Um, Interestingly, anecdotally, I've had people from very conservative religious backgrounds that have come into the trials, though, and actually have had a profound experience and gotten better with it as well. So, it seems to be something that may be that is sort of cross-cultural in its effect.
Yeah. So another question we have is, would it help with emotional regulation or even personality disorders like BPD?
Really interesting question. BPD is a very understudied, but very common mental health issue. It has not been directly studied in borderline personality disorder. I think there is potential to study it, and there have been some groups, making the case to study it for borderline personality disorder. If you look at the depression literature, those that had some personality disorder traits didn't do so well in the therapy. So, um, it remains to be seen, but there's no study as yet that's been done in that population.
Okay, that's interesting. And so you've already touched on the dependence of psychedelics, but someone's asking about the tolerance of psychedelics.
So yeah, it's generally well tolerated. One of the most common side effects are dizziness, nausea, acute anxiety, but that tends to be quite mild and transient, so it resolves very quickly. Generally, they're pretty well tolerated. We have had a couple of cases where the nausea has been so bad that people have vomited. So we've had to give anti-nausea medications. Um, but that's about it really in terms of their tolerability.
Okay. So I understand that the study samples are not as diverse as we would have liked. I would like to ask if you'd expect people to experience different types of hallucinations based on cultural differences.
You know, it remains to be seen. It's even with all our efforts at CAMH and UHN, 60% of our sample has been white, 40% from another population. We haven't noticed any differences in the sort of type or quality of experience. We haven't done the analysis yet to see whether certain cultural or ethnic groups respond better, but that's something that would be interesting to do. Other studies that have had, for example, like a third of people that are Hispanic in the US, they've found that actually the effect was the same in those populations. But it's a very personal experience, right? Like if you are particularly spiritual or religious, then your sort of insight may be very relevant to your particular spirituality or your experience.
Yeah, that's very interesting to think about because there's so much variability within the individual. So it'd be nice to see if there is some variability between cultures as
Yep.
well. Uh,
Yep.
so another question we have is, what do we know about the cardiac risks associated with the 5-HT receptors?
Yeah, so this is a very important one. So there is some sort of with psychedelic use like LSD and psilocybin use, chronic and long-term use associated with some cardiac risk factors, arrhythmias in particular. Um, we haven't seen any of that in our studies, but we don't think the risk is high with a single or 2 to 3 doses. I think it only becomes high with repeated dosing. We do make sure we check ECGs beforehand. Um, but we haven't had any of that, and no study, in fact, has reported any adverse cardiac outcome. So I don't. There, it is a risk though. So we would exclude people with a cardiac arrhythmia or recent cardiac event from our studies.
Okay. The next question we have is, how could someone participate in the ongoing studies, or alternatively, is this type of treatment available for those with depression and anxiety?
So the way the treatment is administered for depression and anxiety is through our clinical trials. We have several of them for depression. And the best way to reach out would be, first of all, is to go to the CAMH website where you can find these studies on the website and sort of volunteer. You could also email psychedelics.research@camh.ca. I'm happy for Harleen for you to share that with folks if you want to. And you can email that email address as well and put yourself forward for the trials.
Yeah, so we've recorded this for anyone that's still here. We've recorded this talk, and I'll be sending out a follow-up email within the coming days so we could add in a bunch of links and resources for anyone who wants more information. So we have two more questions here. One is, do you have any guess as to how many years it might be before we see psychedelics accessible without SAP?
For treatment. So I think probably for psilocybin therapy, within the next 2 years, you would have a sort of determination on whether it's going to be approved by the FDA in the US, and I think Health Canada will follow pretty soon after that. So I would estimate we'll have an answer within 2 years. We don't know yet because the phase 3 studies, which are the ones that confirm safety and effectiveness, are still ongoing at this point. They're scheduled to complete mid next year. So that'll let us know about psilocybin. A lot of you should know that MDMA was put forward to the FDA and was rejected because of some of the limitations in the studies that I mentioned, the lack of blinding, some of the issues with the psychological support and therapy, and how the FDA didn't feel comfortable commenting on the psychotherapy piece. These regulators can only comment on the drugs, not the psychotherapy. So the way that psilocybin is being developed is is more a drug-based treatment with that psychological support really there for safety containment as well. So we'll see. We'll see.
Awesome. I guess this next question is within that same line. What is your prediction on the translation timeline from research to clinical practice? Will we see widespread psychedelic use in psychiatry in our lifetimes?
I do think that this will be part of the treatment options that we will be using because I think that the evidence is strong and even some of the early data from the phase 3 trials is positive. My worry is that in a publicly funded health system where you need specialized staff to support people for a whole day, in its current form, it may not be something that is sustainable for publicly funded healthcare to roll out. I'm not sure, and that's why we have to look at more innovative models, which we're trying to do. You know, maybe reducing the number of therapists or the number of therapy sessions, maybe doing group therapy sessions, pre and post dosing, looking at perhaps shorter acting psychedelics as well. So those questions are yet to be answered. But yes, I do think it'll be part of treatment. I just hope it's not something that, those with financial means to be able to pay for it will be doing.
Mhm. So we have another question from a student here. Why did you choose psychedelics and what did you have to do to get here?
I chose psychedelics because, well, psychedelics chose me. I was approached to study psilocybin because my research background was looking at novel therapies for depression. And so I was approached to take part in a trial for psilocybin therapy, and then I was fascinated by some of those results that were coming out from the UK, and I thought that, what is this magic substance? So I decided to sort of plug away at trying to understand what's going on. Um, what did I do to get here? A lot of hard work. A lot of hard work. I think you just have to follow. You need a good mentor. You need a good work ethic, and yeah, just pursue something that you're interested in. I research is all about persistence, and it takes a lot of getting used to rejection before you make it. So I think it's about persistence.
That's great advice. We have one more question here. Any chance you could name some of the Ontario universities focusing on psychedelics?
For sure. University of Toronto, particularly CAMH and UHN, are doing a lot of work with psilocybin. My colleague at Sunnybrook, Sean Nestor, is also leading some work with psilocybin therapy and integrating neuroimaging into that. University of Ottawa is launching a psychedelic therapy program with Monica Williams there and another colleague. Queen's University has a psychedelic therapy research center. They're looking at microdosed um, psilocybin for generalized anxiety disorder. So those are the main players at this time in Ontario.
Great. So I have one more question that was sent in earlier that I thought would be interesting to answer. As clinicians, how can we address cultural or religious stigma associated using psychedelics as a significant part of therapy?
So yeah, I think that, this is a huge, again, from my own background and conversations that I have with people in my own family about some of the research that I do. They within my culture, South Asian culture, it is still seen as a sort of taboo. It's something that's seen to be sort of an intoxicant that one is not supposed to take. I think like I think a lot of it is about educating folks that the therapeutic use is very, very different from recreational use. This is not something that you will take, to enjoy a night out with your friends or something like that. If you have a mental health problem and nothing else has worked for you, then and your doctor suggests that it may be helpful after you've seen a specialist, I think, you frame it in the way that spiritually, religiously, culturally, it may be acceptable so that you can ease your suffering with specialist support and guidance. And I think that sort of education piece is the way to sort of break down that stigma associated with this. And even other treatments like ketamine, for example. Like ketamine is a street drug, but it's also an anesthetic. It's one of the sort of WHO's essential medicines, right? But people don't somehow have the stigma with it because it is also an anesthetic. And I think it's about educating folks that actually a lot of the medicines that they take could be mind altering. You know, you take morphine and you could have it's an opioid, right? Like you could have sort of an intoxicating feeling with that. Yet people will have surgery and they'll take their morphine. So this is sort of similar. I guess this would be like surgery for the mind.
Yeah, that's a great point. I think communication and education are key points, especially when we're talking about stigma and taboo within our communities. So it seems like those are all the questions that we have. So I'll just hand it over to Jenny to conclude.
Yeah, well, I just want to thank Dr. Husain for an excellent talk and for educating us all about psilocybin. I think the questions were excellent and everyone appreciated having your expertise. So just again, thank you so much for making the time for us. And thank you to all who attended. Harleen will follow up with an email and just keep a lookout for future events. So
Thank you.
thank you and have a good night, everyone.
Thank you.